We now go to the next scenario. In spite of using all the best technologies available today in our preoperative work of the patient, we still land up at times with refractive surprise. So how would one treat this refractive surprise? How would we make this patient happy again? So Dr. Sandeep Nagvekar, who requires no introduction, is going to be talking about treating a refractive surprise with an IOL exchange. And this will be followed by Dr. Sujata Mohan, who is busy in another IC and will be joining us soon, who will be speaking to us on using a piggyback lens in treating a refractive surprise.
So Nitin, thank you for inviting me. Is my opponent coming or she has given up? Okay, so there we are. Oh, sorry. So first of all, the topic says I had a refractive surprise. So the first thing we have to know that I am the surgeon. If I am the surgeon, I know very well what I have done. I know and I will recognize the problem immediately, immediately post-op. So this is the main thing. If you are the surgeon and if you're going to recognize the problem immediately, and if there is no easy solution in sight, by easy solution I mean, suppose it was a toric lens and the lens has not been positioned properly, you can rotate the lens. Or if there is a power problem of about half a diopter, then you can either capture the lens anteriorly or do a reverse capture. And if these solutions are not possible, then in my opinion, the best solution is IOL exchange. Now, why IOL exchange? First of all, it's very easy to perform in the first 3 months post-op. And it's not difficult to perform even up to 1 year post-op. I have done it even 2 years post-op. The power of the IOL is known and the refractive error is known. So because of which you have all this data in hand, it makes it very easy to predict the power of the IOL that you have to now secondarily implant in the patient's eye. And even if the patient has been operated by someone else and the IOL power is not known, in modern technology using optical biometry and substituting the lens status as pseudophakic, it is very easy, and if you know the material of the lens, you can recognize it on the slit lamp. It's very easy to predict the power of the IOL that has to be put in the other eye. The main thing that has always been touted against lens exchange, that it is very difficult to perform. I wish to show you with a small video that it's not very difficult. Now here is a case operated by me, a patient who had a PanOptix trifocal put in her eye, and she was absolutely 6'6" and 5. She deferred this decision till around 3.5 months post-op. But when she was not very comfortable with the glare and halos, and she was a VIP, I decided to go and exchange. It was a femtocataract. Now this is where the most important thing. You take a flat blunt tip spatula and slip it under the anterior capsule and go as far as possible to the periphery. Now this is very important that you open that capsular bag that has shrunk. And with this fat tip blunt spatula, it is quite easy. So go around 360 degrees, especially above the haptic. Now that's that little adhesion that needs to be broken. And I think the game after that is quite easy. So now you go in with heel on, slip your cannula under the anterior capsule, 27 gauge cannula, watch those bubbles as well as the flow of the liquid wave as the visco completely dissects the posterior capsule of the lens from the posterior surface over there. Now with the help of a simple dialer, you start rotating. When you come towards that edge and you find that the tip of the haptic is not going further, it's time to wait, push it back again, don't be too aggressive. It's the reason why it's not happening is because the other haptic is not loose. So now go on the other side, put your dialer over there and gently nudge it out of the capsular bag. Now this is 3 months post-op and you can see that it's not very difficult at all. Now this one will get free. Now you have, with a simple movement, you will have the entire lens in the anterior chamber. And once you have this, then the rest is quite easy-weasy, okay? So next thing, you pull the haptic out of the eye and then go in from the side port and hold the IOL with IOL holding scissors and use the IOL holding forceps and use the scissors to cut this IOL into 3 or 4 pieces, depending on what is required. This was a 30 diopter IOL, so the IOL was quite thick in the center. Now we have an even better solution. Dr. Neha Dolakia has provided us with a very good instrument, an IOL cutting scissors, which is ultrasound based. So you can just fix it to your phaco handpiece and do this easily without even having to open the jaws. You must always keep the AC well inflated with viscoelastic so that there is no risk of rupturing the posterior capsule. Anyway, the blades are always blunt on the other side, so it's very, very easy. All you have to do is make sure that at all times use plenty of viscoelastic. Don't be stingy over there, and you can easily get this out of the eye. For reasons of brevity, I'll skip to the last piece. You have to use now a dialer to feed it in properly into the IOL holding forceps and gently get it out of the eye. And all this is through the 2.2 millimeter incision that you began in the first place. Now you inject the monofocal toric, and it was, as you saw, a toric, and you put a toric back again. And lo and behold, the patient's vision was 6/6 unaided. There was no induced astigmatism. It's very simple. All you have to do is basically make sure that you free the IOL from all sides. Now, why not a piggyback IOLs, as my esteemed opponent will speak on? Remember that two IOLs occupy space, whether both of them are in the bag or one is in the bag and one is in the sulcus. This often leads to iris chafing and the development of the UGG syndrome. It can lead to both a pupillary block glaucoma as well as an angle closure glaucoma. And it can also lead to interlenticular interface opacification. This is well known and documented in the literature. Now, the sulcoflex toric IOLs are notoriously known to rotate within the sulcus, leading to patient disappointment as astigmatism reemerges. And the bioptic pseudophakic vision system does not provide great quality of vision. Speak to someone who's had a bioptic procedure. He has had two lenses, either both in the bag or one in the bag and one in the sulcus. They always complain that when they go out at night, they always see that streak of light emanating from all street lights. That is because of the light getting reflected from the second IOL, okay? And they also complain of loss of contrast. The vision is not as good as the other eye, which may have had a perfect IOL, and other photic phenomenon. So the benefits of IOL exchange, that any IOL, whether it be toric or non-toric, whether it be mono, trifocal or read-off, can be easily implanted. You can once again give the patient great quality of vision. It is a single-step solution to provide the internal refractive element of the eye, which comes somewhat close to the natural lens. And we all know that today's IOLs come quite close to the natural lens, though nothing can ever replace it. And once performed, the patients are very happy and secure in the knowledge that no further IOL-related complications are likely to surface and that no further interventions may be required as explantation of piggybacks that happen sometimes. Thank you so much, very much for your time.